Good morning and welcome to Medicine Grand Rounds. It's really a pleasure for me to introduce one of our own. Cynthia Carlsson is a graduate of the University of Michigan for her undergraduate and her medical degrees, and is actually a native of Michigan. And we were fortunate to recruit her in 1995 to our residency program, and she's stayed ever since, ascending through the ranks as intern resident, chief resident, fellow in geriatric medicine, fellow in Molly Carnes' VA Older Women's Health Fellowship. She also, along the way, picked up a master's in population health sciences. She joined the faculty first as a clinical instructor, then assistant professor, and since 2011 has served as associate professor with tenure in our department. She also recently has been endowed 2 professorships. First, the Vilas Distinguished Achievement Professorship, and in 2016, the Lewis Holland Senior Endowed Professorship in Alzheimer's Disease. She also serves as the Associate Director for the Wisconsin Alzheimer's Institute and is co-director of the Veterans Affairs Memory Assessment Clinic. Dr. Carlsson is very well published. I counted 78 original peer-reviewed manuscripts, as well as numerous abstracts, editorials, and other publications. She's been very well funded by a number of different organizations, including the NIH, NIA, foundation grants, and the VA. She's a very good citizen, serving locally on many committees, and nationally she's recently chaired the NIA Review Committee for Neuroscience Aging Study Section, and currently serves as the chair of the NIA Review Committee for the Beeson Career Development Award in Aging, an honor that she has held. She also volunteers and serves for the Alzheimer's Association, the VA, the American Federation for Aging Research, and the American Geriatrics Society. She reviews actively for a number of high-impact journals and has served as associate editor of the Journal of Alzheimer's Disease. Truly a triple threat. She's clinically active and is very active as an educator at all levels. And I was really impressed looking at the number of mentees she has shepherded through over the years at all levels. Of course, with these accomplishments, she's received a number of awards. I mentioned the professorships already, but within our own department, she's received the University of Wisconsin Department of Medicine Pusto Research Award and our Department of Medicine Graham Meyer Teaching Award. She's given a number of talks locally, regionally, nationally, and even internationally, and we're really fortunate to have Dr. Carlsson as a member of our own faculty today, providing grand rounds entitled Transforming Alzheimer's Disease Research and Clinical Care, What is My Role? Please join me in welcoming Dr. Carlsson.
Thank you, Rick. Thank you, Rick, and welcome to Grand Rounds in this chilly morning. So, again, I'm so thankful to be here, to be a part of this UW and VA community here, and to try to talk to you some about some of the exciting advances and where we are positioned right now is extremely important, again, for helping us transform Alzheimer's research and clinical care. And again, I titled this, What is My Role? Because I really want us to think about how Alzheimer's disease is not really a disease of just geriatricians or primary care clinicians, neurologists, psychiatrists, but really it's a disease that a lot of us as different educators, clinicians, specialists, researchers should be addressing and thinking about in how we conduct our research and our clinical care. So we'll be addressing that today. So again, I do receive grant support from these agencies, but no financial disclosures. So again, what I'll talk about today is, first of all, the importance of early diagnosis for Alzheimer's disease, the role of biomarkers in preclinical diagnosis, where we are with current future strategies in Alzheimer's prevention and treatment, and then thinking about what is my role, and my meaning each one of us in this room. And again, we're really at this critical point, like I mentioned. The number of people with Alzheimer's is dramatically increasing. the clinical trials that we've done in Alzheimer's have failed for the most part, but we're at this critical point where now we have new tools that will help us identify not only clinically whether someone has Alzheimer's disease, but also the biologic changes occurring in their brain before they get symptoms. So again, that's really important because that's going to get us the right people into the trials to make sure that we're actually treating the right people for our prevention and treatment strategies. So I think a lot of us have seen these numbers increasing, so we know that the number of people with Alzheimer's disease is expected to triple in the next coming decades. So again, right now in the United States alone, we have over 5 million adults who have Alzheimer's disease. In developing countries, the rate is increasing even at an even more rapid rate. And you can see a lot of this is driven because of the increasing survival of people into their mid-80s. And while Alzheimer's disease is not a normal part of aging, it does increase with age, which is the #1 risk factor for Alzheimer's disease. So despite this increase, there have been some reports recently that maybe the incidence of Alzheimer's disease is decreasing. So some of you may have seen this article in New England Journal by Dr. Susadri from Boston University using the Framingham heart study, where they found that they thought there was maybe a decrease in the incidence of Alzheimer's disease and other dementias over the last several decades. So what they saw was that there was a decrease in the hazard rates from 3.6 to 2.0 per 100 persons over a 30-year period. And with that same time, what they saw was that the risk factors, vascular risk factors, were declining as well, with the exception of diabetes and obesity, which we know are increasing in our country. So again, some of the hypotheses were, so again, what we know is that the rate of Alzheimer's disease is increasing. Again, there may be a slight dampening of that effect because of more aggressive treatment of vascular risk factors. But again, what's important about this study is that it did not include very many African Americans or Latino adults in this analysis. And why that's important is because African American and Latino adults are at about 1.5 to 2-fold increased risk of developing Alzheimer's disease. And so we know from studies that when we're in our mid-60s, you can see from the first set of graphs, when we're in our mid-60s to early 70s, that about 5-10% of us will be at risk or have Alzheimer's disease. By the time we're in our mid-70s, it'll be more like 20%. And by the time we're over 80, again, we'll probably about half of us, 85, about half of us may end up having Alzheimer's disease. So as we think about the patients walking into our clinic, thinking about a busy clinic panel, think about the number of people who probably are walking through your door who may have underlying Alzheimer's disease. For those of us who work with veterans, this number may be even greater. So again, when we look at the veteran population, and again, there's studies ongoing to really kind of clarify how much greater are veterans at risk for dementia compared to the general population. But the Department of Defense has an Alzheimer's disease neuroimaging initiative that's ongoing, and they're going to look at some of these questions. So hopefully we'll have better answers in the coming years. But again, compared to the general U.S. population, the U.S. veteran population has a constellation of risk factors that put them at higher risk. So again, they have increased risk of vascular risk factors, they have increased prevalence of traumatic brain injury, PTSD, and depression. So these things together, and again, even the PTSD and depression, they think may be related to vascular risk factors. So again, these vascular risk factors are putting our veterans at increased risk, not just for vascular dementia, but Alzheimer's disease as well. Then if you look at that subset of patients in the U.S. veteran population who who are eligible for VA services and receive their care here, again, they're at an even higher risk than the general veteran population. So VA-eligible veterans who use it tend to be a higher prevalence of African Americans. They're also an average, again, this is just an average, but some of them have lower income, less educational opportunities, and more service-related conditions, medical and psychiatric, which again may increase their risk for Alzheimer's disease. So again, as we look at these populations, again, when we see our patients coming through the door, the older patients, if we have patients in their 70s and 80s, thinking about the number, proportion who should be probably having some underlying Alzheimer's disease, whether it's diagnosed or not. If you care for veterans, again, because of that constellation of risk factors, there may be even a higher prevalence of Alzheimer's disease. So with that being said, you'd think, in the United States, the developed countries, we'd have a pretty good rate of diagnosis for Alzheimer's disease. But studies are showing that about 50%, maybe even more like 20% of people who actually have Alzheimer's disease carry a diagnosis. So again, this is in developed countries. This isn't in places where they don't have the resources to focus on cognitive impairment. So again, this really is an impetus for us. If we're going to make a difference in transforming clinical care, if we're going to make a difference in research, we have to be able to recognize this in primary care clinics, inpatient wards, subspecialty clinics heading into procedures. We need to be able to recognize this disease. Many people say, well, why bother diagnosing it? Because there's nothing really to do about it. We know there are not good therapies. We know there's no way to prevent the disease currently. So why even bother with a diagnosis? However, if you look at data, even without good medical therapies, there are ways to help reduce caregiver burden by diagnosing, helping plug in people to resources in the community. It improves quality of life for people. So again, if you talk to people, if you've ever experienced, if you're a caregiver for someone with Alzheimer's disease, or you've talked to caregivers, you know that that diagnosis, plugging them into related resources, is very important for their care. So again, there is a benefit right now even for people to increase their recognition of Alzheimer's disease. So again, as we think about trying to push ourselves to be better at diagnosing this, again, and the trajectory, again, for Alzheimer's, it's a gradual decline. So if you think compared to normal trajectory for normal related aging or aging-related changes in our thinking abilities, over time we'll have symptoms that, before we get dementia, we'll have this condition called mild cognitive impairment. So again, the difference between the dementia and mild cognitive impairment is that dementia has cognitive impairment to the degree that's affecting your day-to-day function, whereas mild cognitive impairment, the person's cognitive abilities are abnormal, but they're functioning okay. They're compensating, making notes, making extra lists. A step back from that is subjective cognitive concern, where people have cognitive complaints, but when you do their cognitive testing, they're actually doing okay. But they're noticing something. Something's different than what it used to be. So again, as we look through this trajectory, our goal is to try to diagnose it not only accurately once the disease is present, but trying to step back and see how early we can diagnose this condition. So the diagnostic criteria for Alzheimer's disease were revised in 2011. The next year, the DSM-5 came out with their criteria for major neurocognitive disorder. So just to make things confusing, they have different names for them. But again, overall, the National Institute on Aging, Alzheimer's Association criteria, and the DSM-5 major neurocognitive disorder, again, the dementia term, major neurocognitive, are essentially the same. There's one difference I'll point out, but overall you can think about them as pretty similar. So again, for a diagnosis of dementia, so again, the larger syndromic umbrella term, you have to have cognitive changes that interfere with a person's functional ability. So that's going to be different for each person. A business executive is going to be different than a carpenter. It's going to be different than a quilt maker. So again, what that person's functional ability at baseline is very different, and that takes questioning, talking to the patient, talking to the family in detail. And again, it has to be a change from their baseline. So it has to be a change from it has to affect their day-to-day function and be a change from their baseline. And it can't be diagnosed in the context of delirium or another medical disorder. So again, frequently I'll get consults in the inpatient wards asking me to diagnose someone with a dementia who's admitted for some other medical problem. When they're in the process of delirium, we're not going to be able to diagnose someone with a dementia. But that being said, for those of us who work on inpatient wards, hospitalists, we need to be aware that that diagnosis of delirium may be a marker that that person does have underlying Alzheimer's disease. So thinking about how can we get that into our discharge summaries, how can we notify the primary care doctor that that may be an issue to follow up is really important. So again, not explained by something else at the time. And then again, the diagnosis is made a combination of history and cognitive assessments. And this can be done in a primary care setting. It doesn't have to be a long, detailed neuropsychological test. It can be a mini mental state exam or a MoCA test or some other cognitive screener, which does have different domains within that test. So again, it could be something as simple as, Mr. Smith is having problems remembering where he places car keys regularly. He used to never do that. Now he's forgetting things regularly, or he's forgetting conversations, he's forgetting important events. And then on the cognitive test, they missed 3 items on delayed recall. So it can be something simple as that. And then you have history and cognitive assessment showing that that domain has been affected, that memory domain. So again, it doesn't have to be extensive. In some cases, more extensive testing is helpful, but it doesn't have to be extensive. It can frequently be done in primary care. And then again, to be diagnosed with dementia, it has to be at least 2 cognitive domains. And so these are the common ones that we think about: reasoning and judgment, memory, language, visual-spatial skills, and then behavior changes, which is more commonly seen in frontotemporal dementia, which we won't address today, but again, can be seen across the other types of dementia. So again, meeting criteria for dementia. So again, you can see that these are things we can commonly do in a primary care setting. We can look for these on the inpatient wards, again, with a caveat that we'll probably need to have them followed up for once their delirium clears in the hospital. But again, this is can be done in a lot of common primary care settings. To be added, the added caveats for something being Alzheimer's-related dementia, again, just has to be a gradual decline. And then, again, usually it's memory, but you can have other symptoms come on first: language, executive function, some other symptoms that come on first, although that's less common. There are other research criteria. I'll talk some about the research biomarkers, but other research criteria that can bolster whether or not you think someone does have Alzheimer's disease. But in the clinical setting, the ones that are probably going to help you the most are documented cognitive decline over time. So again, this could be something like a MoCA test you do at one point in time and 6 months later or a year later. So that's going to be a documented decline. Also, genetic mutations, which again, these mutations that are listed here are less than 5% of the cause of Alzheimer's disease. So this is the familial early onset Alzheimer's disease. So we don't commonly check these genetic mutations in people with the more common form, the late onset Alzheimer's. So if we're trying to diagnose earlier, then why don't we just screen all of our patients? And that's a common thought, a common question. There's still a lot of controversy about that. So in general, the U.S. Preventive Task Force Service in 2003, and then again in 2014, decided that there's not really good data to support screening people who are asymptomatic. So again, the key here is asymptomatic. So, and then with the Patient Protection and Affordable Care Act in 2010, they recommended that you do some type of objective cognitive assessment of patients patients coming in for their annual Medicare wellness visit. So they're a little discordant, but again, if you ask a question and kind of screen them with a question, then you're not doing a full cognitive screen. You're only identifying those who have some symptoms. And so in 2013, Cordell and several other team members developed this algorithm which you can review and kind of get into the habit of using in the primary care setting. And this, again, helps us to identify when to do some screening. So not asymptomatic across the board screening, but again, looking, first of all, asking them, do you have more problems with memory than most people your age? Have you noticed a memory complaint? If they have memory complaints, then developing getting used to using a cognitive screening tool in clinic. If that's abnormal, setting aside a special clinic visit just to evaluate what the causes of their memory problems. If they don't have any complaints, then asking someone who knows them well if they've noticed it. Because again, we know that Alzheimer's can affect the frontal lobe, so then someone's insight into whether or not they're having abnormal cognitive changes is impaired. So again, asking an informant. If the informant says, no, they're fine, so yes, they're normal, basically, then they can just be followed up again the next year. If they are concerned, then again, doing the cognitive screen, seeing what that triggers. If the trigger's normal, then just seeing them again the next year. So getting into a routine where we're routinely asking someone, how's your memory, any problems with your thinking abilities, and then having kind of a set routine that we're used to using in order to make sure that we're diagnosing people early. In order to diagnose people early, again, we need to have good diagnostic services available for people. So again, in primary care settings, a lot of dementia can be diagnosed, but in some cases you need a little more advanced services. So back about 15 years ago, Mark Sager and Bruce Herman, through the Wisconsin Alzheimer's Institute, developed this network throughout the state of Wisconsin to help train primary care clinicians, general neurologists, family medicine, geriatricians to provide good quality dementia care and develop these dementia care services throughout the state. So while most of the population of Wisconsin is in south central Wisconsin, once you get up into the northern parts of Wisconsin, the proportion of people who are older is much higher. So you can see that when you look up there, it's a lot of older adults who are in these rural areas who don't have access to good dementia care services. So what Dr. Sager did and Dr. Herman They partner with these clinics throughout the state. They come down twice a year for training to talk about this model for how you diagnose and treat dementia. And then over time, new clinics form. And now there's a clinic network of about 35 clinics throughout the state that now I've now taken on a role with WAI, the Wisconsin Alzheimer's Institute. We oversee this clinic network, go through the training with the physicians and teams, and the teams are just amazing, providing really high-quality dementia care throughout the rural areas of Wisconsin. So not only does the WAI through UW provide this training, so again, trying to increase access to good dementia care service, but also the VA. So under the leadership of Steve Barzy and some of our neuropsychology team, Barbara Fisher, the VA has developed a teleneuropsychology service that, again, can provide using videos, Video Connect, using Teleconnect, can talk with patients who are in rural areas. Again, older veterans who may be more frail, maybe can't get to Madison easily. They can do cognitive testing with an aide on the other end of this video service, so they can evaluate their cognitive status. And you can see that there's some in the middle of Wisconsin, down into Freeport, and some new planned initiatives in the Upper Peninsula of Michigan. So again, trying to improve, if we're going to improve diagnosis, trying to make sure people have access to good dementia diagnostic services is really important. And in order for people to get into the clinics, we need to make sure that they're willing to come into the clinics, which means that all of us have a job to do in reducing stigma associated with Alzheimer's disease. So even at holiday parties, I expect everyone to kind of do a little explanation about what dementia is and isn't. And one of my stories, I was at Christmas a couple years back, and there were about 10 people in the room, and my husband's side of the family, and I think about 2 or 3 out of 10 had Alzheimer's disease just sitting there. And I was looking around the room, and they were talking, and someone said, well, so-and-so thought they had Alzheimer's disease, but thank goodness it was only dementia. So I said, all right, so how do I integrate a little dementia education into this family Christmas event? So again, I think, we really have a role in trying to reduce stigma of Alzheimer's disease, helping people to realize that it's not a normal part of aging, but it is more common as we get older. And so one initiative that our WAI group in Milwaukee is doing, so led by Gina Green Harris and Stephanie Houston and Nia Norris, what they're doing is leading this Amazing Grace chorus, and this chorus is made up of people who have Alzheimer's disease and their caregivers, and other people from the community as well. But again, what it does is gets people out in the community who have Alzheimer's, shows people that you have a life with Alzheimer's disease, you can still enjoy life, and that reduces a stigma, so they're more willing to come in to see their doctors and to be diagnosed and to realize that it's not doesn't mean that they have to withdraw from society with the diagnosis. So again, within a clinical evaluation, again, a standard clinical evaluation, you're going to go through their medications, physical exam, these detailed could be abbreviated cognitive tests, some basic lab tests. Everyone should have some type of neuroimaging, either a CT scan or an MRI, within the context of when they had their cognitive symptoms begin. So if they had cognitive symptoms that's been going on for 2 years and had an MRI 5 years ago, they might need some repeat head imaging. Whereas their symptoms began 2 years ago and they had a CT scan of their head for falls last year, that should be fine. Again, they should have education and feedback. And then, again, some of the key benefits right now are plugging people into good resources. These are some of from helping oversee our memory clinic here at the VA for the last 15 years or so. These are, if we can remember these 4 things to check on your patients, you'll find a lot of potentially reversible causes of dementia or reversible causes of cognitive impairment. So really trying to do a good job of reviewing people's medications, looking for adverse effects, making sure their vascular risk factors are tightly controlled. Again, that Framingham data, the reason the incidence might be going down is because we're doing a better job of treating vascular risk factors. So if they won't address their blood pressure for cardiac prevention, maybe they will for Alzheimer's prevention. So screening for depression and treating that, and then also sleep apnea. So I'm very impressed with the impact of sleep apnea on cognition, both the insomnia but also the hypoxia associated with sleep apnea can have profound effect on cognition. So again, as we go through these, even in a primary care setting, we should be able to improve our diagnostics using these tools. So again, but we don't want to really wait till someone has Alzheimer's disease. So again, we're focusing on trying to identify the disease before someone gets symptoms by using these preclinical biomarkers. So again, the other picture that I showed, it showed that cognitive decline, but you can see in the backdrop of this, you're having increasing Alzheimer's pathology. And Alzheimer's pathology probably starts at least several decades, 2, maybe 3 decades before your symptoms start. So if I'm going to get Alzheimer's disease, I may have plaques and tangles in my brain right now and may get Alzheimer's disease in 20, 30 years from now. So again, why this is so important, if we're really trying to push to diagnose the disease earlier, then we really need to think about what are the earliest brain changes we can detect. And some of those brain changes, that was my little trick here. Okay, there we go. So some of the brain changes, again, if you look at the top brain as an older adult who died from another condition besides Alzheimer's disease, you can see that there's normal neurons, tissue around the neurons. But if you look at the brain of someone with Alzheimer's disease, you see these typical plaques and tangles. So again, the plaques are made chiefly up of a protein called amyloid, and the tangles have these interneuronal changes, these hyperphosphorylations of a protein called tau. So you'll have the tau and the amyloid, the tangles and the plaques. But there's also more than amyloid. So a lot of our therapeutic interventions have focused on amyloid. But again, there's also other changes going on in the brain. So again, whenever our neurons activate, there's this coupling with the vascular blood flow. So again, the neuron activates, it signals for the local microvasculature to dilate, so you have an increased blood flow to that region. And then there's retrograde signals that are sent up to dilate the blood vessels further up, so you get increased blood flow to that region that's active. So again, what we have is then this neurovascular coupling. You have astrocytes linking the neurons to the local capillaries and arterioles. And then, again, this important interaction between amyloid, these plaques and tangles, and the vasculature to that area. So as you have decreased blood flow to a certain region, you have increased plaque formation. The more amyloid you have in the region, it affects the blood vessels so that they reduce the amount of blood flow to that region. So you get this vicious cycle of not only the neurons being damaged, causing problems with the vessels, but the vessels over time, if someone has lots of vascular risk factors, that's going to increase how much amyloid is deposited in that region. So again, a lot of our clinical trials have focused chiefly on trying to get rid of those plaques, where there's a lot of other potential targets, including vascular risk factors and vascular dysfunction, that may play an important role also in Alzheimer's disease. So again, with Alzheimer's disease, again, if we're trying to get back and get to that subjective cognitive concern and trying to really identify someone with normal memory who's going to develop Alzheimer's disease, then again, we don't want to wait till someone has clinical symptoms. We want to use biomarkers to identify their symptoms early. And so to do this, we're partnering with 2 large important cohorts here at UW. In partnership for that, we have an overall initiative to end Alzheimer's, which is comprised of both the Wisconsin Alzheimer's Institute and the Wisconsin Alzheimer's Disease Research Center. And so the focus of these centers are slightly different, but very collaborative. So then the ADRC more focuses on the biology of aging, the biology of Alzheimer's disease, biomarkers, clinical trials, but also some research on models of care. And the Wisconsin Alzheimer's Institute, again, helps support WRAP, which looks at early biomarkers, models of care, health services, but it also does a lot of important outreach, implementation science, and public health. So again, trying to reduce the stigma, get people into the clinics, get them into research, and then on the other end too, getting good quality research to get that back into the clinical practice. So again, part of the Alzheimer's Center has mild cognitive impairment in Alzheimer's patients, as well as middle-aged adults who are at risk for Alzheimer's but cognitively healthy, and older adults at risk for Alzheimer's who are cognitively healthy. Whereas the WRAP cohort, housed at the Wisconsin Alzheimer's Institute, has a cohort of about 1,500 people who have, about 2/3 of them have a parent with Alzheimer's disease, 1/3 do not have a parent with Alzheimer's disease as a control group. So again, these cohorts together are trying to help us look and see what are the very earliest changes we can see in the brain that could help us identify who's at risk for Alzheimer's, again, with the goal of trying to get them into these prevention studies and really try to modify the disease before it causes symptoms. So again, the ADRC has 780 currently, and the WRAP cohort is 1,500. And these are what the cohorts collect. So again, with the Wisconsin ADRC, it has from age 45 and up, has people with normal cognition, all the way up into their 90s. We have people who have mild cognitive impairment and people with Alzheimer's disease. In the RAP cohort, that has over 1,500 people, they started with a middle-age cohort, 45 to 65, and are followed every several years over time. And you can see each of the cohorts started at different times. RAP in 2001, ADRC in 2009. They collect data every other year. They have very extensive cognitive testing, information on lifestyle factors, medications, medical conditions, and also have a subset who have these very important biomarkers. So neuroimaging, cerebrospinal fluid, and some with some molecular imaging as well. So these are the basis for a lot of the work that we do, the RAP and the ADRC, and you'll hear us talk about those. And so again, even though this is just a line and a number, these numbers are amazing people. These are people who come back repeatedly, who are extremely dedicated to this work, who are great partners in this. As well, I'm not allowed to put their names up here. Again, these numbers represent a lot of diligence, people taking time away from their work to help us find answers for this disease. So some of the markers that we're focusing on, I won't be able to talk about all of them, but again, some of the markers include various neuroimaging MRI scans. And in particular, some of the ones we're most excited about recently are some of the ones that look at brain blood flow, both at this tissue level, but also at the macrovascular level as well. There are also measures of atrophy, so looking at brain shrinkage over time related to neuronal damage, neurodegeneration, and white matter changes as well, which affect the tracks of the in between the neurons, the axonal tracks, and the integrity of white matter. We also have PET imaging now that does not just look at glucose uptake, which reflects the health of the brain, regional activity of the brain, but we also have now amyloid imaging and tau imaging. So before, where we could only look at the amyloid and tau changes in someone who had passed away and looking at their autopsy specimens, now we can look at people who are asymptomatic, maybe have a parental history of Alzheimer's disease, to see if they have these changes in their brains. And then my favorite area, cerebrospinal fluid biomarkers. So again, the CSF biomarkers can give us valuable information about not only amyloid, tau, but also inflammation, neuronal health. So again, partnering with all these tools together, we can really get a better picture of how healthy someone's brain is over time. So again, using MRI scans, we can look at, we talked about how we get down to that microvascular level. You have that neuronal coupling with the arterial spin labeling MRI. That's a tool where we can really look at that tissue perfusion at a small scale and see what is the blood flow to various small areas that may be very important for memory and learning. And so this, again, that kind of coupling with the neuronal activation and microvascular flow. And so on the bottom here, that just shows what some of the images look like for this brain blood flow using arterial spin labeling. And studies have shown that when you use this tool, that there are reductions in certain areas of the brain that are important for memory and learning in blood flow. So there are regional changes. So again, people who have Alzheimer's disease, those areas of the brain have reduced blood flow to those important areas. But what does that mean? Does that mean that there's neuronal damage and the blood flow is just not being called to that area? Or does it mean that there's actually reduced blood flow that's triggering some of that neuronal damage? And so that makes a big difference in what kind of focus you have for treatments. If it does seem that the vascular disease is increasing or accelerating the Alzheimer's disease changes, then it may be important to address vascular risk factors. There's also a newer technique developed by Oliver Wieben and Pat Tursky here at UW in Medphysics and Neuroradiology. And what this tool does is this looks at more of the macrovascular changes. So what the top images are 3D reconstructions of the brain, the arterial system in the brain. And you can see what they do on the middle slices here. You see the little blue slices through these arteries then can be measured. And the reason it's called 4D flow is not only is it a 3D reconstruction of the vessel, but you're also getting the flow across that point in time. So you get a time component to it as well, the fourth dimension. And it can also be gated to a cardiac cycle. So you can see here in the lower corner that it can be related to the cardiac cycle. So then you can look at pulsatility indices of this. So again, this is another important tool that helps us to look quantitatively at the blood flow to certain parts of the brain. And so with 4D flow, again, what we're finding and what this graph represents, these are some data that Leonardo Rivera worked on using data from our Alzheimer's Disease Research Center in partnership with Oliver Wieben and our team. So again, in people with Alzheimer's disease, they tend to have the darker bars, so the less disease they have, the lighter the bars go. So what this graph shows in each of these different segments of these arteries, that you can see that the mean blood flow decreases the more disease somebody has. So across all these different various segments, that in this cross-sectional analysis, blood flow is reduced in people with more Alzheimer's disease pathology. And inversely, people who have more disease have stiffer vessels in their brain. So people with Alzheimer's disease in this subset where it was actually cardiac gated, you can see that the people with Alzheimer's disease in general tended to have greater pulsatility index compared to those who had lower risk for Alzheimer's disease. So again, these are from our Alzheimer's disease research cohort, again, supporting that these vascular changes do relate to underlying disease pathology. So the other tool that we have is these amyloid and tau images with PET scans. So again, this is a 70-year-old woman who has been having cognitive decline, but not mild cognitive impairment or other disease. And you can see that on the middle scan, the greater areas that show red here show where there's increased amyloid deposition. And then on the your far right, there's increased tau deposition or tangle formation in this person. So even though they're asymptomatic, they're having changes of Alzheimer's disease in their brains. So again, these are exactly the type of people that we want to get into prevention trials and try to modify their risk for progressing to Alzheimer's disease. For CSF biomarkers, again, this is for Dr. Safdar. I wear a mask when I do these, but there's an old picture before we had the infection control guidelines changed. So that was my little graphic to show. It's an old picture. So again, cerebral spinal fluid collection. Our team's done over, or probably I've done over 1,200 lumbar punctures. Our nurse practitioners over 300. So again, we do a lot of these procedures. They're very well tolerated. Some people do get headaches, less than 2%, though thankfully this is a small risk. Again, we have a tiny needle we use, but the cerebral spinal fluid is so important. It gives us unique information that right now we do not have blood tests that can help us with the pathology that we can see in CSF. And these are some of the things we can see. We can see tau changes. We can see gliosis changes. We can see axonal injury, measures of inflammation, measures of amyloid changes over time. So again, looking more closely at the more specific levels of those plaques and tangles, also what those plaques and tangles are doing to the environment of the brain. So what happens over time, again, as the amyloid comes out of the spinal fluid, the levels in the spinal fluid come down because they're going into the brain. And then as there's neuronal damage and the cells die, they release the tau into the CSF, so then the tau levels increase over time. So your CSF amyloid levels go down over time, and your tau levels go up with disease progression. So in this example, what these are 500 people from both the Alzheimer's Center and the Wisconsin Alzheimer's Institute. People with the red circles are represented, those are the patients with Alzheimer's disease. People with the open blue are people with mild cognitive impairment. And the middle-aged and older healthy controls are the squares and the triangles. So you can see that people with Alzheimer's disease, again, have that higher tau level and that lower beta amyloid levels in their CSF results. People with mild cognitive impairment look fairly similar to that. They have those higher tau levels, lower beta amyloid levels. People who are cognitively normal, again, for the most part, they have lower tau levels and higher amyloid levels. The amyloid has not been deposited into the brain yet. So again, we can use these markers. These are cross-sectional, but what we really want to find out are, what about these people in the middle who kind of look like maybe they're going towards that Alzheimer's pattern? Can we follow them over time to see if they're going to progress? So that's what we've started doing, is to follow longitudinally with the cerebral spinal fluid measures in our cohorts, both the Alzheimer's Center and the RAP cohort. Well, what about combining some of these markers? So again, this is an analysis that was done by Annie Racine and Sterling Johnson's lab in partnering with using RAP participants. And what they looked at in this analysis was looking to see how do these PET images relate to the spinal fluid markers that we see. And it did show that people who had a greater increase in amyloid load in their brain tended to have lower spinal fluid levels of the amyloid in their spinal fluid. So again, it also predicted who was going to have more amyloid deposited in their brain over time. So again, piecing these tools together, piecing the PET with the CSF gives us even more information and answers more questions. So again, it supports that there's a decline in the spinal fluid, but it's getting put into the brain even in cognitively healthy middle-aged adults. Well, how about combining factors in another way, looking at various clusters of these biomarkers? So this is another paper that Annie Racine worked on, again from Sterling Johnson's lab, where she looked at both RAP and ADRC participants, again, cognitively healthy people. These are not people with disease. They're middle-aged for the most part. Women, 2/3 or more, have a family history of Alzheimer's disease and had about 6 years of follow-up. And so they looked at these clusters, these MRI clusters, spinal fluid clusters, and broke people up into 4 groups. The first group looked like they had Alzheimer's type pathology. Second group looks like maybe it was a mix of Alzheimer's and vascular disease. The next group looked like it was pathology but not Alzheimer's. And the last group looked fairly healthy. And so what she found in this was that those who had that kind of cluster that looked more like Alzheimer's disease, and these are cognitively healthy middle-aged adults, they did tend to have cognitive progression over time in episodic memory. So again, being able to use these biomarkers, identify who's at risk for cognitive decline, and then getting to the point where we look at how can we use this for prevention and treatment. So right now, I've had this same slide. I think I changed the picture just for my own interest's sake, but I've had this same slide since 2003 because we've had no new treatments for Alzheimer's disease since 2003. The different formulations, combination pills, long-acting, there's no new approved drugs since 2003. So again, we do have medications. We treat it with cholinesterase inhibitors, with NMDA antagonists. So we do have agents that help slow symptomatic disease progression. But again, they're really only targeting the neurotransmitters in these dying neurons that are being damaged by the amyloid plaques and tangles and the neuroinflammation going on around. So really it's just trying to help these dying neurons function as best as possible. They do have a role, though. I still use them. They're recommended. They're cost-effective. They do have effect in delaying symptomatic progression. But again, they're, again, since 2003, we've had no good new approved medications. So this is why we do research. This is why we want new targets for research. We want to get our patients into these trials so we can find ways to prevent Alzheimer's disease and treat it more effectively. So again, if you start someone on one of these agents, it will delay the progression, but it's not going to get them back to where they started. So again, we do recommend using them, but as a clinician, and I'm sure a lot of you feel the same, that I'm very dissatisfied with what I can offer my patients right now. So why are our clinical trials failing so miserably in Alzheimer's disease? One thing is that it's difficult to develop good animal models because the animal models usually are either amyloid or tau. Tau is harder to find, but these animal models of just amyloid, they're not replicating what happens in human brain. And plus, how do you replicate, the subtle nuances of human expression, human behavior, memory? Swimming around in a water maze is not quite the same thing as, forgetting how to manage your business. So again, it's really difficult because of these difficulty with animal models. And then until recently, we didn't have very many biomarkers to identify what's going on in somebody's brain. So again, you could have somebody who looks exactly like they had Alzheimer's disease, or they could have had hippocampal sclerosis and no amyloid in their brain. So you're giving them anti-amyloid therapy, you're trying some other trial, and you're not treating the disease you think you are. Now that we have these imaging tools and these CSF tools, now we can understand better what are we doing, what biologic targets do we have, and how is it affecting the person. So most clinical trials now will look at cognition, how it's affecting their day-to-day life, and these biomarkers. So we really know, what are we treating? Is it really doing what we think it is? And then a lot of the studies have focused on beta amyloid pathology for drug development. So again, they haven't looked at the other vascular effects or the other inflammation as much. Again, chiefly focusing on amyloid pathology. And again, getting drugs across blood-brain barrier is difficult. And then also the trials didn't include people who are most likely to decline. We all know that clinical trials tend to want to make sure they get the healthiest people who are going to finish the trial into the study. So then you're excluding people with vascular risk factors, which are going to increase your risk of Alzheimer's disease. And then the other thing is that over 90% of NIH funded and 97% of industry supported trials were in non-Hispanic white adults. So if Latino adults and African Americans have higher rates of Alzheimer's disease, and we're excluding people with other diagnoses that increase their rates of Alzheimer's disease, we're not studying the right populations. So I think finally we're waking up and realizing this, trying to include more diverse participants in our studies, and now we have the tools to look and see what's going on in their brains, as well as clinically how they're doing. So this is one therapy that's been, again, focusing on amyloid to start with. Anti-amyloid therapies have been the mainstay of a lot of clinical trials in recent years. And so you've probably heard in the news some news about this solanezumab as one of these anti-amyloid therapies, a monoclonal antibody, and it was published in several papers. So one, a trial called Expedition 1 and 2, which looked at solanezumab infusions once a month for 18 months in people with moderate Alzheimer's disease. They found a signal where people who had milder symptoms seemed to be doing better. So they launched another study called Expedition 3, which just was released, the information was released the other day, and again found that treatment with these anti-amyloid therapies in people who already have Alzheimer's disease did not make a difference in their risk of cognitive decline. But again, I was just on a call the other day, there's a little bit of a signal still that people who are even earlier may benefit from this. So again, it may be that if we target this amyloid in people who've already had all this inflammation, neuronal irritation, and damage, it may be too little too late. And so there's still a big impetus to see if we use these anti-amyloid therapies earlier in the course, will that make a difference? And the A4 study that I'll tell you about is looking just at just that. Other therapies using for treatment of Alzheimer's disease that are under investigation. So again, there's other types of antibody therapies that are under investigation. There's other medications that reduce amyloid aggregation or production, so BACE inhibitors, and even things like some various cardiovascular medications like carvedilol is under investigation because it may have an effect on beta amyloid aggregation. And also therapies that help prevent tau formation. So even diabetic medications that we commonly use may have a role in affecting tau phosphorylation. Again, there's medications looking at neurotransmitters, therapies to reduce inflammation. So again, we're expanding beyond amyloid, still looking at amyloid, but expanding beyond amyloid to hopefully get some better therapies. Intranasal insulin is being studied, as well as other therapies that are, again, trying to focus on improving blood flow and see if that makes a difference in Alzheimer's risk. Again, there's no established preventive therapy, no FDA-approved therapy for Alzheimer's disease prevention. But these are the types of therapies that are under investigation. Again, some similar to what's being looked at for treatments. Amyloid therapy, as we'll talk about in a minute. Statins, which are an area of interest for me. Blood pressure medications. Again, intranasal insulin. A variety of nutritional agents, which may have antioxidant properties. And then the MIND study is a combination of the Mediterranean diet and the DASH diet, trying to see if that may have a role in preventing Alzheimer's as well. So what about anti-amyloid therapy in people without Alzheimer's? So if these studies are supporting that we need to keep moving earlier, so I guess from your side we need to keep going this way. So whichever way is earlier. So again, the A4 study is really a landmark study, and we're thankful to be a site here at Wisconsin. It's a study led by an investigator, Risa Sperling at Harvard, and it's supported by NIH and Lilly. And what it is, it's a 3-year clinical trial where somebody's coming in, a cognitively healthy older adult, 65 to 85, coming in, and we're using one of these tools to see, do they have the brain changes that we think are going to increase their risk for Alzheimer's? So they get a PET scan to see if they have increased amyloid deposition in the brain. If they do, then they're randomized to either the infusion, the anti-amyloid infusion, versus a saline infusion monthly over a 3-year period. So again, it takes we have to screen about 20 people to get one participant because of the rate for the number of people who end up having elevated amyloid in the brain. But again, you're getting down to people who really have the disease in that preclinical state. So again, we're starting to use these tools in these landmark clinical trials. And again, hopefully, we'll see what the study shows, that we'll see if by altering amyloid in the brain before we have any cognitive decline, can we kind of protect that cognitive trajectory over time in these at-risk adults? So if you know of someone who wants to be part of this study, we're still recruiting. And one thing that the study is really emphasizing too, which I think is important, is that they purposely let it be messier, let people with all kinds of medical problems come in, and also they're trying to get 20% of people from underrepresented backgrounds into the study. They're still making pushes and trying to make progress. It's still not quite there yet, but again, really trying to make sure that these studies are representative of who's at risk for Alzheimer's disease. In my studies, I've looked at trying to see does statins have been shown to reduce amyloid in animal models. Can we see if statins reduce cerebrospinal fluid measures or alter the cerebrospinal fluid levels of beta amyloid? And in our 9-month clinical trial with simvastatin, we found that there was not a change in the amyloid levels in people who are at risk for Alzheimer's, with parental history of Alzheimer's. So again, these are 100 people who are like their RAP-like participants, impact-like participants, but no change over 9 months with simvastatin. However, what we did see is that we found that these statin drugs in 3 clinical trials now have improved blood flow to certain parts of the brain that are important for memory and learning. And also in one smaller study did improve cognition in certain domains. So does improving blood flow mean they're going to have less risk for Alzheimer's? That's what we still have to investigate. But again, it's promising that there's regional improvements in blood flow using these therapies. So one study that we're just launching was approved yesterday. And Elena, who's my coordinator here, is helping over and it's her birthday today. Happy birthday, Elena. So the BRAVE EPA study is a study where we're trying to look and see, let's partner with our veterans who are, again, at higher risk for Alzheimer's disease. This is a fish oil-derived therapy in the background of this. So fish oil, DHA, and EPA together have been shown to look at some of these factors we're talking about, improving blood flow, reducing beta amyloid. And so now we want to see if these types of therapies will work in people. There already has been one study, again, in Alzheimer's patients, not at risk, but where they used DHA. So in this study, what we decided to do is to focus on the EPA component, which may have less negative effects on LDL. Again, EPA and DHA both lower triglycerides, but also may have these other effects on trying to improve risk for Alzheimer's disease. So this is an 18-month clinical trial. We'll be recruiting 150 veterans, middle-aged adults with parental history of Alzheimer's disease, and they'll be randomized to icosapent ethyl, which is a purified EPA known in the United States as Vascepa, twice daily versus placebo. And again, we're trying to see, is this going to increase blood flow? Is it going to reduce some of these spinal fluid biomarkers? Is it going to improve cognition? Again, a proof of concept study to see if some of these vascular modifying agents might have a role in Alzheimer's prevention. So we're just starting to recruit. So if you have veterans who are interested, we will be glad to enroll them. Another study that's going to be focusing on cardiovascular prevention is the EXERT study. So this is a study for mild cognitive impairment patients. Again, trying to see if exercise will help reduce risk for developing Alzheimer's disease. And that's led by Dr. Okonkwo here at UW. Other resources for referring patients, the Alzheimer's Center is actively recruiting patients. There's also clinicaltrials.gov, and then the Alzheimer's Association has a resource. So if you have patients who are interested in being involved in clinical research, please, please, please encourage them to do so. And this gets us to our final point. So what is my role in transforming Alzheimer's clinical care and research? So the first is, again, we haven't had a new medication since 2003. We really need people into clinical studies to better understand the better outcomes for studying in clinical trials, to be involved in clinical trials. I used to be a little nervous about talking about research, and I don't want to push too hard, but as a clinician, it's very unsatisfying. And as a daughter of someone whose mom died from Alzheimer's disease, again, it's very unsatisfying to know that there's not many treatment options right now, and that the only way we can really get to better treatment options is by being engaged in research and encouraging and giving our patients permission, encouraging them to be a part of finding these answers. So as a primary care clinician, again, what I would recommend is that we work hard together to screen for and effectively diagnose Alzheimer's disease, to educate patients, families, and trainees about what Alzheimer's is and is not. that we review for medication effects, depression, sleep apnea, again, with the goal of trying to improve their cognition. And then encouraging middle-aged patients to really optimize their vascular risk factors and lifestyle factors. Again, we can't prove that it reduces risk for Alzheimer's disease, but we know it has effects for cardiovascular prevention, so it may just be another motivating factor to help them reduce their cardiovascular risk. But again, we're hopeful that that may actually reduce risk for Alzheimer's as well. And then encourage them to be engaged in Alzheimer's research and treatment trials. Again, a lot of our patients will be like, well, I need to ask my primary care doctors. They trust us as their primary care doctors and want to have us be the gatekeepers, make sure we give approval, and we take good care of them. They keep coming back, so please, please engage them in research because we need answers. What about specialty care clinicians? Again, referring patients with cognitive concerns. There's a big push now. Again, people in the inpatient wards who have delirium probably have some underlying Alzheimer's disease or some other dementia. So again, referring them for evaluation, considering the impact of cognitive impairment on your education and treatment plan, thinking about the risk of delirium before procedures in someone who has Alzheimer's disease, and understanding the impact of the diseases you treat. Cardiovascular medicine, diabetes, sleep apnea, all these conditions may have a role in preventing Alzheimer's disease. And then again, encouraging research. So I'm going to stop there. We have a huge team, and this isn't even everyone. Alzheimer's Center, our VA team, our Wisconsin Alzheimer's Institute team, and our participants are just amazing. So I'll stop there. Thank you.
Thank you, Cindy. That was outstanding. I'll ask you to call on the audience for hopefully condensed questions so we can get a few in.
Yes, Chuck.
Great talk. Is the incidence of sleep apnea so high in dementia that everyone should have a sleep study similar to everyone getting some scan of the brain?
So the question is whether everyone with dementia should have a sleep study if the incidence is so high. I don't know if we fully know what the true incidence of sleep apnea in dementia is yet. So again, we're not even fully diagnosing everyone who has dementia, and I think that our understanding of how many people with dementia actually have sleep apnea is a problem. But what I would do is if somebody's coming in and having cognitive complaints, again, to ask them about their sleep, to kind of ask some screening questions. And then there's a pattern that actually one of our clinics up in Eau Claire noted is that if they have more problems with learning or immediate memory in their cognitive tests compared to their delayed memory, that may be a sign they have sleep apnea. They're finding increased frequency there. So I'd use it more as something to screen for if someone's coming forth with cognitive complaints, more so than, but we do in our patients with dementia too, we'll ask them about their sleep and see if they need a sleep study. But we don't do it across the board in everyone. Yes, Mihai. Oh, yeah.
Sleep question, does it seem to be hypoxemia that's the main issue, or just persistent drowsiness?
So the question is whether the sleep issue is related to hypoxemia or the persistent drowsiness, and which is causing greater cognitive changes. Probably both. So again, the hypoxemia is probably contributing. Again, sleep apnea is going to affect blood vessel risk factors, vascular risk factors. The insomnia is going to contribute as well. And there's other mechanisms that are starting to be more strongly linked between Alzheimer's and sleep dysregulation. So there's probably even more than we fully understand linking those two conditions. Yes?
About 6 months ago, there was an article in Scientific American talking about the role of sleep in clearing the brain of amyloid
Yes. Mm-hmm.
and other ways of products. Could you comment on that a little bit?
Great, thank you. So you mentioned that there is an article that was published recently about how sleep has a role in helping us clear some of these products related to Alzheimer's disease. And that's true. Again, they think that when we are sleeping, we may have better beta amyloid clearance, again, which would mean less amyloid deposit in the brain in the long run. So again, another reason for us to get good sleep. So you residents who are on call tonight, make sure you try to squeeze in a few hours. But again, there is a lot more research focusing on that integration between sleep and Alzheimer's as potential contributor to Alzheimer's disease.
We have time for one quick question from Dr.
Oh.
Carnes.
So the Women's Health Initiative found that those women randomized to postmenopausal estrogen therapy almost doubled the risk for Alzheimer's disease. So I'm wondering for older women, do you have any specific recommendation for postmenopausal hormone therapy?
So the question is, since the Women's Health Initiative showed an increase in risk of Alzheimer's disease in people who are randomized to the postmenopausal hormone therapy. So what recommendations we would have for postmenopausal women who maybe need hormone therapy. And so Dr. Asana, who's here, has done research looking at estradiol and estradiol patches in postmenopausal or perimenopausal women and showed that it did not increase their risk of dementia if you use perimenopausal estradiol patches. So not the Premarin like was used in the Women's Health Initiative, but estradiol, which is more of a natural type estrogen, longer acting with the patch. So again, that's what I would probably recommend is they use estradiol for their symptoms.
And with that, we'll have to close. I want to wish everybody happy holidays, and I want to thank Dr. Carlsson for an outstanding grant.